Welcome to the Deep Dive. Today we're getting into a really fascinating case study of how a small, well-intentioned change in a massive medical system can have these just dramatic, unintended consequences.
I have a perfect example.
We're talking about lung cancer screening, or LCS, and specifically the internal language that guides those life-saving scans. That's the Lung-RADS system.
Right, the lung imaging reporting and data system from the American College of Radiology. And that standardization is absolutely essential.
It has to be.
Lung cancer screening, performed using low-dose chest CT, it provides a huge mortality benefit for high-risk patients.
Yeah.
And because of that success, the program is just growing so rapidly.
What kind of numbers are we talking about?
Well, we saw 2.2 million of these LCS CT exams done in the U.S. in 2022. It's a huge jump from just a few years before. So the system, it has to be efficient to handle that kind of volume.
Okay, so let's establish the mission for this deep dive. Our sources are all looking at this critical transition between the older set of rules, Lung-RADS version 1.1, and the newest system, version 2022. And the goal here is to understand how one key revision, a change that was supposed to bring this surgical precision to certain ambiguous findings, instead led to a massive increase in, well, unnecessary follow-ups.
And it diluted the whole value of the program. And we don't even have to wait for the shock statistic. It's the mystery we're starting with today.
Okay, lay it on us.
So when V2022 introduced this new Category 0 option, specifically for findings that looked like they might be infectious or inflammatory, well, radiologists started using it twice as often as the old similar option.
Twice as often, so more follow-ups.
Way more. But here's the critical data point. Get this. Of all the cases that were classified under that new V2022 Category 0, 0 were malignant. Not a single one.
Zero.
And you compare that to the old systems category, where 22% of those cases ultimately turned out to be lung cancer.
Wow. Okay, 0 versus 22%. That's a staggering shift in the yield of the classification system. It immediately signals a widespread misapplication.
Exactly. This new category that was supposed to refine the high-risk group suddenly became this bucket for all these low-risk findings.
So before we dissect the exact technical changes, we need to zoom out and talk about the context. Why does this doubling of unnecessary follow-ups matter so much?
It matters because of who we're screening. The guidelines have expanded now, so they include people 50 and older with a 20-pack year smoking history. That's a huge pool of people entering the screening system.
And while the benefit of finding an early cancer is massive,
Right.
The downside of screening is always the false positive results.
Always. And false positives, they aren't just a nuisance on some spreadsheet. These are findings that look suspicious enough to warrant more imaging, maybe an intervention, or these short-term follow-up scans. But they turn out to be completely benign.
And for the patient, that's just pure anxiety waiting weeks or months for clarity, plus, extra radiation exposure. And for the healthcare system, it's just wasted time and money.
Exactly. We know that false positive findings are a major issue in LCS. Some studies show that, roughly 13% of findings on these exams might end up being false positives.
13% is a lot.
It is. And the real problem, child, the thing that complicates management the most, is infectious or inflammatory processes.
Okay, so why is inflammation such a confusing issue in lung scans?
Because the imaging findings can genuinely overlap. A finding that might be an active, aggressive, infectious process, like, say, a case of pneumonia, it can look really similar to an early aggressive malignancy.
I see.
Up to 8.7% of patients in screening have findings that are just from a simple infection or inflammation. And even though patients are screened when they don't have, active symptoms, things like asymptomatic infections are still really common.
So Amorines has to draw this razor-sharp line between benign inflammation and a high-risk malignancy, or else we're all just wasting resources chasing shadows.
That's the job. And dealing with that fuzzy boundary is where the classification system really earns its keep.
Okay, so let's look at the evolution of the rules, starting with the old system, V1.1.
Right, so V1.1, which came out in 2019, it used Category 4B for these tricky cases. Now, generally, a Category 4B classification means there's a high suspicion for cancer.
Okay, high risk.
Very high risk. But the system had this specific option within 4B for new large nodules that radiologists really suspected were just infectious. And the recommendation was an aggressive 1-month follow-up CT.
And as we saw in the data, classifying those findings as 4B proved to be highly selective and, highly valuable.
It was. 22% of those cases turned out to be cancer. The system was working exactly as intended, flagging these high-risk scenarios that really demanded that close surveillance.
Then came the V2022 update, and this
Yeah.
is where that subtle but seismic shift
It
happened.
really is. The system removed that 4B option for suspected infections and replaced it with a brand new Category 0.
Categories.
Category 0. It was described as findings suggestive of an inflammatory or infectious process, and it recommended a slightly longer but still short-term 1 to 3 month follow-up.
What's really key here is the shift from calling it a variation of a Category 4B high suspicion to giving it its own category, Category 0. I mean, that just sounds inherently safer or at least less scary to a radiologist.
It does. It lowers the perceived risk. But the strict intent behind the new Category 0 was precision.
So what did the guidelines actually say?
The V2022 guidance was extremely specific. It said Category 0 should only be reserved for findings that truly mimic high-risk lesions, but where infection is still highly likely. This includes things like multiple new nodules, more than 6, or a new solid nodule that's at least 8 millimeters,
Okay.
or a finding called segmental or lobar consolidation.
Wait, I need you to unpack that last bit for listeners who might not be looking at CT scans all day. What does segmental consolidation actually suggest, and why does that automatically put a radiologist on high alert?
That's a great question. So, in layman's terms, consolidation is just an area of the lung that's filled with fluid instead of air. And segmental or lobar just means it's covering a large, defined section of the lung.
So a big
Dense patch.
Hmm.
When a radiologist sees that, it often looks like severe pneumonia. But, and this is the key, if that consolidation doesn't clear up quickly, it can be masking a very aggressive central cancer. So, reserving Category 0 for these big, potentially dangerous findings. It made sense, theoretically.
So the goal was to keep the bar high. Only the scariest, largest findings that look like a real problem get this short-term Category 0 follow-up. What did the guidance say Category 0 should not be used for?
This is crucial. The guidance specifically warned against using Category 0 for certain really common infectious patterns. For example, findings like tree and bud nodules or small, new ground glass nodules less than 3 centimeters.
Okay.
The guideline was explicit. These findings often reflect simple, self-limiting inflammation, and they should just be classified as Lung-RADS 2.
Which is just routine annual surveillance, a 12-month wait.
Exactly. A totally different pathway.
That is critical context. The rulebook said, use Category 0 sparingly, only for the big, aggressive-looking findings. So now, let's turn the page from the textbook and see what actually happened when these new rules hit the real world across those 14,000 patients in the study.
And the real-world data immediately tells you the guidance just wasn't followed. When we compare the application of these categories, the old V1.1 Category 4B option for infection was used in 0.4% of exams. 55 cases.
Yeah, okay, 0.4%.
The new V2022 Category 0 option was used in 0.8% of exams, 88 cases. That doubling of usage was statistically significant.
That's a drastic failure of efficiency. That increase from 0.4% to 0.8%, it translates to dozens of extra unnecessary scans.
That's battle anxiety for the patient.
Exactly, and an extra radiation exposure for patients who ultimately had nothing to worry about. But the most damning evidence is the yield. Tell us again about those malignancy outcomes.
The difference is so striking, it's worth repeating. The old V1.1 Category 4B system, which had that high-risk label, it successfully captured 22% malignant cases. They were correctly identifying the right people.
Right.
The new V2022 Category 0, which was used twice as often, captured 0 cancers, a 0% malignancy rate.
I have to push back a little here. Wasn't this change actively causing harm by just generating pure waste? If a system change doubles the workflow and returns absolutely nothing of value, hasn't the attempt at precision actually undermined the whole purpose of a value-based screening program?
That is exactly the conclusion the authors of the study suggest. I mean, the majority of the V2022 Category 0 classifications, 98% were benign.
98%.
And you could even see how benign they were by how quickly they resolved. Findings they put in Category 0 were far more likely to just shrink or resolve completely at that first follow-up 81% resolution, compared to the old Category 4B findings, where only 53% resolved.
It's conclusive proof they were chasing low-risk shatters.
Total shat.
So if they weren't finding these high-risk nodules that then cleared up, what were radiologists classifying under Category 0? This gets right to the core of the misapplication.
Right, so let's look inside the old versus the new buckets. In V1.1 Category 4B, the findings that gave them that 22% malignancy rate were the appropriate scary findings. 65% were solid nodules and 24% were part solid nodules. dense, defined masses.
And when we switch over to the V2022 Category 0 group, the picture just changes entirely.
It does, a total change.
Huh.
The V2022 Category 0 findings were just dominated by these low-risk characteristics that the guidelines explicitly said may not warrant a short-term follow-up.
Like what?
Well, the most common finding was ground glass nodule, or opacity. That was 43% of the cases. The second most common was tree and bud nodules, at 13%. So together, those two finding types made up 56% of all the Category 0 classifications.
For our listener, we really need to clarify what that visual difference is. You said solid and part solid nodules were in the high-risk group. A solid nodule sounds like what it is, a dense, defined tumor.
Right. Think of it like a marble in the lung tissue.
Okay, so what does a ground glass nodule look like, and why is classifying that as Category 0 a misuse?
A grain glass nodule, or opacity, it looks hazy, like you're viewing something through frosted glass. It's soft, translucent. It often just represents slow-growing, atypical cells, or way more commonly, just simple inflammation or fluid that's going to resolve on its own. It doesn't have that aggressive look of a solid nodule.
And tree and bud.
Tree and bud is a classic pattern you see with an active infection, like certain types of bronchitis. It literally looks like small buds on a tree branch, which just signifies inflammation down in the small airways. It's almost always indicative of infection, not cancer, in this population.
So the study sample just reinforces why this misuse matters so much. Across all the patients they analyzed, the malignancy risk for part solid nodules was high 23%. For solid nodules, 11%.
Right.
But for the findings that radiologists were frequently putting into the new Category 0, the ground glass opacities and the tree and bud patterns, the risk was 0%.
The conclusion is just inescapable. The frequent misuse of Lung-RADS 0 for these low-risk findings was the engine driving this whole increase in unnecessary short-term follow-ups. It suggests that when radiologists were faced with a new, less high-risk sounding Category 0 versus 4B, they just defaulted to it.
Out of an abundance of caution.
Exactly. An abundance of caution, despite the strict guidelines that said these specific findings should just be routine annual surveillance.
It seems like that subtle change in wording from new large nodules in the old version to the broader, more ambiguous findings suggestive of an inflammatory process in the new one, it just created this loophole for human fear.
The fear of missing a cancer.
Right, and that fear then undermined the system's efficiency, and the clinical impact of this imprecision is real. It's increased patient anxiety, low-yield imaging, higher costs. It's effectively devaluing the screening program.
That psychological element is so critical. And our sources point out this isn't an argument against the radiologists. It's an argument for better systems, for better training. Continuous education and feedback are essential as practice adapts to V2022.
The guidance just has to be followed.
It has to be strictly adhered to. Reserve Category 0 for new, large, solid nodules, multiple new nodules, or consolidation, the findings that truly resemble high-risk lesions.
What's fascinating to me here is the suggestion that we might need technical solutions to solve what's really a human interpretation problem. The study suggests things like decision support tools where a computer helps verify the classification.
Or even structured peer review.
Right, to put guardrails around the interpretation process and just ensure classification accuracy.
Yes, because the system needs to be bulletproof. If the goal of Lung-RADS is value-based care, maximizing benefit while minimizing unnecessary intervention, then future versions have to provide more clarification on Category 0. They need to close that linguistic ambiguity that allowed radiologists to incorrectly apply the label to low-risk findings.
Driving up costs and anxiety with zero clinical benefit.
Exactly.
So let's bring this all back to the main takeaway for you, the listener. A new, sophisticated guideline, Lung-RADS v2022, tried to introduce surgical precision by creating this new Category 0, but the real-world outcome was that radiologists just over-applied it. They classified low-risk findings, which had a 0% malignancy rate for short-term follow-up, and they sacrificed efficiency and value in the process.
And this leaves us with one final provocative thought to consider. We often assume that updates to critical systems, especially in complex fields like medicine, are inherently improvements. But in this case, a seemingly small wording change like replacing a specific term like new large nodules with a more general phrase like findings suggestive of it, inadvertently led to the doubling of unnecessary medical actions.
A huge ripple effect.
Huge. So when the stakes are this high in terms of cost, anxiety, and the effectiveness of a life-saving program, how much risk of ambiguity can we really tolerate in the quest for precision? That's something to keep mulling over until the next deep dive.